Now we're going to hear from Louise Byrne. Louise, are you here? Yes, beautiful. Dr. Louise Byrne works with the mental health sector from the perspectives of her own experience of significant mental health challenges, use of services and recovery. For over 15 years, Louise experienced hospitalisation and extended periods of debilitating mental unwellness before finding her niche as a lived experience practitioner. Louise has worked from her lived experience in a variety of roles in government, non-government and tertiary settings since 2005. Her current position is at Central Queensland University, Australia, where she is employed as a full-time lived experience mental health academic. Louise's PhD explored the emerging lived experience workforce in Australia. So please welcome Louise.
Hello everyone, thanks for having me. As you'll have noticed, I'm limping around, so I'm the walking wounded today. I've just got my phone up here. It's definitely turned off, but I like to try and keep to time so we've got some time for questions at the end, so that's all that's about. So as Faith said, I had sort of 15 years of service use, and that included involuntary admissions and all manner of things, all sorts of horrible stuff, as well as some really beautiful moments. So I feel like the richest part of what I bring to my work is always those experiences. And is it working now? Okay, how are we going? Is that okay? I can't tell, so just shout out if it goes off. It sounds the same to me. Basically I feel like the richest part of what I bring to my work is always those years and those experiences. But since then I have been fortunate enough to work in a range of roles. I was actually a peer support worker for a FAMS program in the non-government sector, which was really interesting and really introduced me initially to that idea of policy and how important it is to have policy that supports lived experience work. I've worked in government services and child and youth as well as adult services. I've done sort of like recovery workshops, that kind of thing. I've worked as an in-house recovery expert, I guess, working from my lived experience within a government service. And then, of course, the last 5 years I've been in academia teaching and doing research. So I guess what inspired me to do the PhD research was my own experiences, particularly in that the way I was received within organisations was very variable. And what I wanted to explore was whether other people were having that experience of sometimes being accepted and sometimes not being accepted, and what that meant for us as a workforce in terms of how we're able to develop and go forward. So effectively that was the focus of the PhD, or that was the impetus behind the PhD. I'd just like to clarify some term use, as Faith's spoken about earlier and different people have discussed. Anthony gave us a list of many different terms which all describe different types of lived experience work. So within my work, I like to use the term lived experience practitioner because I think it encompasses all those roles. And particularly because some people have very strong feelings about terms like consumer advocate, like the term consumer. Some people have some very strong negative feelings or positive feelings about peer, and I was just trying to find an umbrella term that would allow me to speak about the lived experience workforce broadly. So, next. Can you tell me I'm not good with this stuff. Excellent. No, I've done something. Great. Okay, so I'm not going to go on and on about research, but this is just to sort of give you a sense of where my work is coming from. The aim of the research was to explore the perspectives of lived experience practitioners, what we're talking about as peers here today, regarding their employment within the wider mental health workforce in Australia, with a specific emphasis on factors that assist and inhibit LEP roles, or lived experience roles, and to ensure the inclusion of rural and regional perspectives. Now again, that's because I'm a rocky girl, Rockhampton, Central Queensland. We've just been on the news for Cyclone Marsha, and coming from a regional area, I'm very aware of the discrepancy between metropolitan and rural and regional areas, and I'm very passionate about ensuring that lived experience roles are occurring in rural and regional areas as well. It's really exciting, particularly exciting for me to be presenting here today because there's so many researchers that I've cited in my work, particularly Larry and Leanne and Anthony. So it's great to put a face to a name and also to be presenting on the same bill. I'm quite chuffed. So the research design, again, I won't go into this in too much detail, but it's a grounded theory method which basically emphasises, it looks at areas where very little is known, and it's all about respecting the data. So basically you're attempting to give as pure an audience or a moment, a voice to the participants as possible. It's all about allowing the participant's voice to be heard. And I felt that was particularly important in this case when lived experience views are so rarely represented within research. Basically, there's just levels of coding in GT. The reason I want to show you this is that the participant sample was fairly small. We only ended up with 13 participants, and that wasn't because there was a lack of respondents. In fact, there was an enormous amount of respondents. But what we found is in grounded theory, we keep working. We go through a constant comparative analysis. So basically, we do an interview, we analyse the interview, we use that data to tell us where to go next. And then you get to a point where no new concepts or no new issues are emerging from the data. We reached that actually after about 8 interviews. But I was like, well, goodness me, it's a PhD, I can't stop now. So, we did a little bit more and used some expert, guidance to make sure that we were verifying the concepts and different things like that. But as you'll find from my talk, my findings really mirror Larry's findings, really mirror Anthony and Leanne's findings. And I think that what it actually tells us is that the similarity of issues is really universal across the board, and that lived experience workers are experiencing the same things no matter where they're sitting in a very consistent way that we can measure very consistently. So in my case, participants were recruited through a range of lived experience networks, district, state and national levels. They represented, and this is important, a broad range of employment situations and were purposefully sampled to ensure that initially we had the widest range of perspectives possible. Why am I so bad at PowerPoint? Okay, so basically, we did not have all states represented, but the geography was very varied. So we did ensure that within those states, there was a wide range of rural, regional and metropolitan perspectives. Every time, sorry. Okay, so just to clarify what I'm talking about there, so we've got participants were identified as working within, physically within metropolitan areas, within regional centres, that were within proximity of metropolitan areas, because I think this is important in Australia. We need to remember that some people can drive to a metropolitan centre in a couple of hours, whereas some people cannot. Some people it's over a day's worth of travel to hit a metropolitan centre, and so many of our mental health services are not provided in those regional and rural areas. So participants were within metropolitan, regional centres within proximity of metropolitan areas, and regional centres that were not within proximity of metropolitan areas, that is a greater than 2-hour car drive. Districts with both rural and regional characteristics, so that a regional area would be like a smallish town and possibly some mental health service areas, whereas a rural area would have no services available whatsoever. So basically what I'm trying to draw as a picture is that the people who participated in this research came from all sorts of areas within Australia and represent the voices of many different geographical situations and everything that goes along with that. The types of organisations were really varied. So again, this is where all the sampling stuff comes in. It's about selecting, the right people so that you get the broadest range of perspectives. So we had government, we had non-government, and we also had what I'm identifying as lived experience NGO, which is lived experience run organisations. That is lived experience at all levels of management, employing a large amount of lived experience people. That's about it on that. The scope and the focus of the role, again, was across, some of them were district-wide, some were district, state and national. We had district and state, we had national, we had international. So again, the participant group was across basically all of the facets of peer work or lived experience work that you can imagine, and representing those perspectives. And why I think this is important is that the findings, and this is a little diagram, because GT is all about diagrams. Gee, they love them. Basically, when we were looking at the data, the themes that were emerging from the data basically all related to the issue of efficacy or the efficiency and evolution of the role. So everything that people said that was relevant to this study ultimately sat under the umbrella of efficacy and evolution of the role. Now, I did anticipate quite a lot of the findings for this study, having been in a range of roles myself and having a range of experience. I was fairly certain that I knew some of what was going to come up. What was shocking to me was one of the major categories, which I've termed, these are the words that I've pulled from participant interviews and then from verification. Stigma, as we've discussed, seen and unseen, underlies the lived experience of work. And basically, if we break that down a little bit, what was happening, which was quite shocking to me in interviews, was that sometimes all participants were identifying some level of stigma or discrimination, but quite a number of participants would start the interview out not identifying as being discriminated against within their workplace. But as the interview progressed, it became apparent that discrimination and stigma was so prevalent within their role that it had become invisible. And this was just this thunderclap. I had no concept that anyone could even be in that position where they were discriminated against so much that it would become a normal part of their work experience. And yet, for many people, it had. So there would be this light bulb moment somewhere within the interview where they would sort of stop and make some type of comment, and there would be this realisation that what they were accepting as normal behaviour and as acceptable workforce conditions was in fact stigma and discrimination. The implications for this, I believe, for both lived experience workers and people with a lived experience in the community are really strong. What it tells me, and what I think future research will show us, is that stigma is still so rife that to be in a role where everyone knows that you have a mental health challenge is to receive stigma and discrimination at this rate. It gives us a poor picture of what that means for people in the community who are trying to share their experience or gain support or be known for who they are and what it is that they are living for. It tells me that stigma and discrimination is the greatest enemy of mental health in this country and of recovery and of everything that we're trying to achieve. People just never learn, do they? Okay. So what we discovered was that some places or some people were experiencing significantly less stigma or discrimination than others. And what was happening was that when there were more supportive factors in place for that person, there were greater benefits both to consumers of services or service users as well as lived experience practitioners. So the lived experience practitioners in organisations with more supportive benefits were gaining more from their involvement in the lived experience role. They were gaining more satisfaction, it was enhancing their recovery, they were feeling great about what they were doing. The people who engaged with that service were also gaining more from that lived experience role, okay? In the organisations where there were more inhibiting factors, the lived experience practitioner was exposed to more risk, and that also meant lower benefits to the consumers. So what we're effectively trying to do is reduce the risk, create more supportive factors, and therefore have more benefits to both consumers and lived experience practitioners and the organisation itself. Yep. So this just gives you a very brief overview of all the ideas that came together to tell us this. it's not really something that we need to go into for very long. The barriers to lived experience in the workplace, as you can see, included poor recovery uptake and recovery denial. I just want to hit on a couple of these because I feel like they haven't been covered. But basically, denial of recovery is also known as clinician's delusion, and it's often found within acute care services where people don't see people getting better. Now, what this means for lived experience or peer roles is that if the people around you don't believe that recovery exists or can happen, your role is redundant. There is no role. You either weren't unwell enough in the first place, you're not like their consumers and you're not relevant to them, or you have no value. So you're like a little frog on a rock, and there's nothing that you can sort of do. Stigma and discrimination was experienced, and I will just touch briefly on, I think, a question that was directed to Leanne about government and non-government services. The early findings of my research indicate that people in government services are less likely to be embraced. And the reason that we believe that is that the medical model concepts, which do sit in contrast with recovery concepts, they're two very vastly different models of care. Medical model concepts are still much more prevalent within the government service because there are a higher number of traditionally trained mental health professionals and a much longer history of engaging with those medical model concepts, whereas the non-government sector is much younger and has been fed recovery ideas from for much longer within its existence. So basically, where there was less good recovery uptake, terrible grammar, denial of recovery, or a higher degree of attachment to medical model concepts, there was greater stigma and discrimination and more barriers for lived experience practitioners. So factors for success, I'm going to go through this as quickly as I can. Planning and preparation. So before you bring people in, considerable time is given to consultation with lived experience leaders and groups and research to inform the development of positions, position descriptions, and change management practices. This is very important, and infrastructure is addressed, again, in consultation with your lived experience leaders and research. Current roles are reconsidered and in some cases redesigned, informed by research, best practice, and potential future expansion. Start at the top. This is really important. This was a really key theme. Many of the participants discussed this. Upper management needs to understand the principles, the language, and the background of lived experience work, as well as the benefits to service users, and they need to promote the idea of lived experience leadership of recovery concepts. So this valuing of lived experience roles at a senior management level needs to also translate into appropriate remuneration, workspace and resources, and access to training. All of this needs to filter down and at every level, so it cannot be skipped. You can't go management, leave out a level of management down here. It's a whole of workplace approach. So the culture of the workplace must be inclusive and recovery focused, or willing to be recovery focused. Senior team members and so on need to communicate to every member of their team the same sort of principles. What is the value of lived experience roles? Why are we bringing them in here? What is their history? What will our service users benefit from this? What will you benefit from this? Employ the right person for the right job. This is just a little quote, which I think touches on something Faye said earlier about tokenism. You can't just plonk any old person in a lived experience role because they happen to have had, a bit of hospitalisation or what have you. There's a broader movement. Depending on what the role is, that person needs to have an understanding of the concepts that inform that role. So in a peer support role, having training in intentional peer support or one of your other specialised peer training or a willingness to do so is really important. If you're working at a systemic advocacy level, if you're a consumer advocate within a government service and they're expecting you to sit with heads of department, then you need to understand how to communicate in those meetings. You need to understand how to read policy. You need to have the confidence to be able to discuss those things. So not just any consumer will do. Just quickly. Reasonable accommodations. When I say reasonable accommodations, I'm talking about the type of workplace that is flexible for everyone. So how do we look at the needs of somebody who might have a mental health challenge, and how do we translate that into a whole of workplace benefit for everyone? I'll leave that for you to think about yourselves. Discussion and respectful debate is encouraged. Rather than whispering about people behind their back or having private opinions that you never share, let's get an open dialogue happening. That's where we can challenge things. That's where we can start to change perceptions and form new concepts of what the role is, what it means to have a lived experience, and all those kind of things. Uniqueness is preserved. This is essential. So what you were talking about earlier, there is a great risk, particularly while the roles are not well understood, that that lived experience roles will be co-opted and forced to perform duties that don't allow them to shine, that don't allow them to come from the unique body of knowledge that is most valuable. So that's something that we really need to be addressing in a range of ways. The ongoing commitment. So the existing paradigm will not change quickly, and it doesn't, bringing an emerging workforce who is so widely stigmatised, it's not an easy process. It needs to be an ongoing commitment to provide periodic and ongoing refreshers for people within the workplace. So that workplace culture stuff needs to continue on and on. Have a willingness to improve your recovery uptake of your workforce and your organisation, and that means be willing to go back to the drawing board. What is our framework? What are our policies? Where can we shift things so that we can become more genuinely recovery focused? And you benefit, not only the lived experience practitioners benefit from that, but at every level, service users and your their colleagues, everyone benefits. Lived experience practitioners must be able and enabled and empowered to take leadership roles in the ongoing recovery training and implementation. This is where the unique body of knowledge sits. This is personal recovery. This is also about collective understanding of recovery over centuries.
I didn't do it.
Is it back? Okay. So recovery is not well understood within the wider sector, as we know. The lived experience practitioners are your best resource. They're your most valuable asset. And of course, create more senior positions, which other people have already talked about. So just in conclusion, the most helpful thing organisations can do is to genuinely embrace the lived experience or peer role by understanding its value, where it comes from, how it potentially impacts on a recovery-orientated system, then engage meaningfully with the lived experience or peers in your workplace, allow them to do their best possible work by ensuring good collaboration and buy-in from other workers. Together, both the peer workers and the wider mental health sector can then evolve into full potentiality and realise the goal that we all share of a truly recovery-orientated system. Thank you.